So today we'll be discussing about pathology. I'll be giving the introduction of the subject of pathology. Pathology is a subject which deals with, it is a study of a disease. Path means disease and study means logos. It is derived from the Greek language, and it is a subject which is usually based on the study of structural, biochemical and the functional changes which occur in the cells, tissues and the organs that underlie the basic disease. So any disease is usually based on the changes occurring at the tissue level, cellular level, or otherwise at the organ level. So pathology is a study which deals with those to identify those changes which occur and helps to identify the underlying cause of the disease. That is the reason behind the disease. So it is based mostly, it utilizes certain techniques, that is a molecular technique. Molecular technique, for example, to say, is a kind of polymerase chain reaction technique which identifies at the molecular level, that is to say about at the DNA level, that is which is a genetic material, which holds a genetic material of a human being. And it also deals with the microbiologic techniques. Suppose if any disease consists of any bacterial infection or anything, then this bacterial infection can be exposed to culture, and then we can come to a conclusion which bacteria is causing the disease. So this is one of the technique which can be used in pathology, and the other technique is immunological technique. Recent advances have introduced a technique known as immunohistochemistry technique, or otherwise radioimmunoassay technique. These techniques are usually based at the level that they use certain stains which consist of antigen and antibody reactions once they bind with the human tissue, and then further they show the exposure of the structures which have been masked by our tissues. So this is the immunological technique. Coming to the morphological technique, are simple staining techniques which are most commonly used in day-to-day life. That is to say hematoxylin and eosin stain, which helps to identify the morphological structures of a cell tissues. So pathology is a subject which attempts to explain why and wherefore of the signs and symptoms which manifested by patients, while thereby providing a rational basis for any theory, that is a clinical therapy or any clinical care to be taken. So this subject deals in diagnosing a disease, thereby the patient can be advised for further therapies, that is under medication. Patient can be advised for medication. So it is a subject which serves as a bridge between basic sciences as well as clinical medicine and scientific foundation for all of the medicine. So pathology deals with majorly 4 aspects of a disease process which forms the core of the pathology. First starting is etiology, to know what is the reason behind a disease. That is to know so that once we find the reason or the cause which is behind the disease, we can drive it out, and further we can help the patient to be cured. And then pathogenesis. Pathogenesis is actually a state where from the cause to the it is a time lag that occurs. It is a step-by-step process from the time the cause, that is the etiological agent, has attacked a patient, to the time where the disease shows clinical signs and symptoms. So this is what pathogenesis is. Then coming to the molecular and morphologic changes. Based on the pathogenesis, there will be molecular as well as morphological changes. Molecular changes, as already told, could be at the DNA level or otherwise at any basic ultrastructural level, whereas morphologic changes, these include the cellular level or tissue level changes. And coming to the clinical manifestations, that is the patient's complaint will be mentioned in the clinical manifestations, where the patient is having a pain, inflammation or so on. So coming to the etiology, where we'll be describing briefly about the etiology. Now, so etiology, as earlier mentioned, it is a cause of a disease, or otherwise it is a pathology. So it usually consists of etiological factors, could be hereditary, that is it could be because of any defect in the gene, or otherwise a defective any chromosomal abnormality which causes defect in the entire offspring. So this could be an example of hereditary damage could be given of a genetic injury, that is any changes in the alterations in the genes, that it could be a translocation or any otherwise it could be a translocation. Coming to congenital, the congenital diseases are diseases which are because of which have been carried from a parent to the offspring. These include mostly the defects such as cleft lip and cleft palate, most commonly seen in dentistry. Coming to the metabolic defects, because of the damage in any amino acid chain or otherwise in any protein sequence, that is there will be misfolding of the proteins which will affect the further processes known as apoptosis, which is a kind of cell death. Coming to deficiency, if there's any intake, if there's any inadequate intake of vitamins or anything, then there will be deficiency. We can give an example of vitamin deficiency. In adults it may cause osteomalacia, whereas in kids it causes rickets. Coming to traumatic injury, it could be a lethal injury or a non-lethal injury which might cause lacerations or any bruises. And coming to allergic injuries, a patient might be allergic to any kind of dust particles or otherwise to any carbon monoxide particles, which might result in asthma kind of disease. Coming to neoplastic disease, which is an uncontrolled growth of a cell, usually seen in cancer patient, which is because it could be also because of an unknown cause or also a hereditary. Idiopathic causes, that is again cancer could be told as an example, because cancer in some patients comes without any cause, without any presence of any hereditary qualities or otherwise without any abnormalities in the body. And coming to the degenerative causes, usually we see a bone degeneration or any neurodegenerative disease because of any damage to the damage at the cellular level. Coming to iatrogenic, it is because of certain treatments like in chemotherapy patients, we see there is loss of hair, alopecia can be seen. So this could be an iatrogenic injury or an iatrogenic cause. So this finishes the etiological factors. Coming to the pathogenesis, it is usually it is a biological mechanism where we find that a disease state can be reached because of a step-by-step process, because of an etiological agent which progresses in its nature. So it could be acute, that is in sudden and onset, or otherwise it could be a chronic, that is long-term causing a pathogenesis, or otherwise recurrent, that frequently recurs. That is, a patient might be cured of a disease once, but again recurs, that is after a relapse. So pathogenic mechanism of a disease or a condition, they are set in motion by underlying etiological causes. So the main reason for pathogenesis to take place is etiological cause, that is it requires a perfect etiological agent for it to reach a disease state. Coming to cell injury, it is usually injury which has been caused at a cellular level. It could be a lethal injury or a non-lethal injury. Lethal injury, it is really harmful to the patient, but non-lethal injury, it is not harmful, whereas it recovers. And cell injury, it can also be of two types, that is reversible injury and irreversible injury. Reversible injury is a state when a cell, it attains any injury or it is exposed to external stimuli which is causing injury, and this external stimuli is in such a way that it only causes injury to a certain limit that the cell can restore back to its normal function, whereas irreversible cell injury means that the cell cannot revert to its normal function, where it further undergoes death in the form of necrosis or apoptosis. So, and coming to adaptive responses are the adaptive features, that is the adaptive normal function of a human body. When there's any injury, the human body tries to overcome this injury with the help of certain adaptive responses such as hypertrophy or hyperplasia or metaplasia or atrophy. Like when there's any bruise or any laceration in the finger, and you see that there is a damage with certain edges in between the finger, certain edges between the laceration, and this laceration after few days we observe that there is recovery of the skin totally. There will be complete recovery of the skin in such a way that there will be cell division of the epithelial cells. Say if the skin laceration is in the skin, there will be epithelial cells start multiplying such that they completely overcome this laceration and then cover up the wound by forming into getting restored into a normal skin. So this is what is hyperplasia. It is a kind of adaptive response. Similarly, hypertrophy, there will be increase in the size of the organ because of increase in the cell division. And metaplasia, it is change in one form of a cell into other form, where we can see that there is a transformation of columnar epithelium into metaplastic epithelium, into there will be transformation of the columnar epithelium into squamous epithelium in cases of allergic conditions, which is a kind of adaptive response. So cell injury which is progressive, that is when your injury is becoming progressive to the patient, then then the cell, it undergoes death in the form of necrosis or apoptosis. Necrosis is a kind of death which is because of an enzymatic digestion, that is the functioning that it functions because of the enzymes, whereas apoptosis is a programmed cell death which occurs and which removes the unwanted cells. So there's a diagrammatic representation showing cell injury. So in cases of reversible injury, when there is a mild and transient injury, the cell tries to adapt. That is, cells showing adaptation in the form of hypertrophy, hyperplasia, metaplasia or atrophy. And then cell reaches to a normal state. That is, in the restoration of a cell to normal functioning is known as homeostasis. Suppose the cell injury, it undergoes an irreversible injury, that is the external stimuli or the injurious agent which is so severe that the cell cannot again retain into its normal position or normal functioning system. Then cells tries to it is enabled to adapt to these adaptive responses, so it undergoes cell death. The cell death could be in the form of apoptosis or necrosis. So coming to the causes of cell injury, it is because of the oxygen deprivation. That is, when there is oxygen content is decreased in a cell body, which is being carried in the form of blood or otherwise be inhaled in the form of oxygen through our nose. When there is any deprivation, that is any disorders in the lung could also cause this decrease in the oxygen levels in the body. Then this could be one of the cause for cell injury, because there will be a state of hypoxia, which is decrease in the oxygen level in the body. It could also be because of physical agents, that is any traumas or any fractures. So chemical agents or drugs, these are the agents which usually cause drugs which may have side effects and cause any harmful effect to the human body, like any detoxification of a drug occurs in the liver, so it might affect the liver by as it gets detoxified, it may become toxic to the organ which has detoxified itself. So liver could be the target organ for most of the drugs which are being used. Or also it can be because of chemical agents like mercury chloride poisoning or otherwise methanol or cyanide, which are truly harmful substances for human body, since they carry all the toxic substances within the human body. And coming to the infectious agents, it could be a microbiological origin, that is, it could be bacterial, viral or fungal, which causes cell injury. Coming to the immunological reaction, so any abnormalities in the complement system, that is the system which is majorly involved in a process known as phagocytosis, where the external injurious infectious agents or the cellular debris are usually eaten up by a process known as phagocytosis, where they are removed from the body through phagocytic cells. So this phagocytosis can be mediated by the complement system. So complement system is a kind of immunological function. So any abnormalities in this complement system can also be resulting into a cell injury mediated by immunological reactions. Coming to genetic derangement, as already explained, any translocation in the chromosomal arms in a daughter chromatid or the offspring chromatid can result in genetic derangements. It could be say sickle cell anemia can also be an example, where it is because of a derangement in the molecular level in the human body. And coming to nutritional imbalances, it could be because of improper intake of inadequate intake of vitamins, as already given an example of illustration of vitamin D, which causes rickets in children and osteomalacia in adults. So coming to the morphological alterations in the cell injury, usually since the stress and the noxious influences, they exert their effects at the firstly at the molecular level or the biochemical level. So these effects are usually take a long duration of time to occur. They could be histochemical effects or ultrastructural techniques or the molecular techniques. Histochemical or ultrastructural techniques usually takes a time period of several minutes to hours, whereas the molecular techniques, that is, the changes start manifesting from few hours to, it may also take few days. So there is a picture showing the sequential development of the biochemical as well as the morphological changes in cell injury, that is the histochemical part or the ultrastructural part, or morphological or the biochemical changes. So the left side of the axis shows the effect, that is, it could be a reversible cell injury or otherwise a irreversible cell injury, and the y-axis shows the duration of the injury, where they can be seen that the time taken for the injury to show its biochemical alterations in the cell death to the time taken for the ultrastructural changes which appear under light microscopic changes, and that gross morphological changes can also be seen. That is, gross morphology is a section of a tissue which is being taken, and in this gross morphology we can see the changes. That is, gross morphology is a step which is being done before it is being observed under a microscope, where the tissue is being cut from a human body and taken to a pathology lab, where this will be processed further into thin sections which are cut, and further they'll be stained, and then they'll be mounted on a microscopic slide, and this microscopic slide will be viewed under microscope based on the requirement. It could be a light microscope or an electron microscope, or whereas various other microscopes. So the changes in this way it could be seen, that is the gross morphologic changes and the light microscopic changes. Coming to the mechanism of a cell injury, usually there are several principles which are relevant to most forms of cell injury. Coming to the response of a cell injury, this response of a cell injury, usually it depends on the nature of the injury. That is, it could be a lethal injury or a non-lethal injury. That is, it could be a harmful injury or a non-harmful injury to a human being. And otherwise, it also depends on the duration of the injury. That is, the time period, the external stimuli, that is the stress being held on to the human body, the stress being resisted by the human body can also be based for the response to be given by a human. Then again, its severity also depends. Then coming to the consequences of the cell injury, it depends on the type, state and adaptability of the injured cell. So it could adaptive. So consequences, that is the further changes in the cell, it depends on the cell, that is the cell, the way it takes up the stimuli, that is the injurious stimuli, the way it takes up the injurious stimuli, it depends on the consequences. That is, suppose if there is a reversible injury, then the cell can adapt by the processes of hyperplasia or hypertrophy, atrophy or metaplasia. Suppose the cell is undergoing an irreversible injury, then the cell cannot adapt. So this is what explains the mechanism of cell injury. Coming to the biochemical alterations in a cell injury, usually we find when a cell is being exposed to an injury, that is there will be decrease in the oxygen in that area of the injury. That is, there will be decreased oxygen tension in the area of cell injury, which ultimately causes loss of oxidative phosphorylation, which is a metabolic process where there will be energy production. So there will be loss of this oxidative phosphorylation, which requires the presence of oxygen for this process, metabolic process, to happen. So ultimately there will be decrease in the ATP, because since oxidative phosphorylation is a process which provides energy to the body in the form of ATP, that is adenosine triphosphate, this ATP generation will also be decreased. So ATP is required for the sodium pump. Sodium pump is a phenomenon where there will be influx of sodium, then even the maintenance of the water content within the body. So there will be loss of this sodium pump, that is, there will be loss of water as well as loss of sodium, thereby there will be influx of calcium. So sodium pump is a process where there will be calcium which will go out of the cell membrane from one solute to another solute, whereas the sodium and the water move from the opposite area to the area where the calcium has been exit. So there will be, because of the loss of escape of calcium from out of the cell membrane, there will be influx of the calcium, that is, there will be increased in the presence of the calcium within the membrane, by which there will be loss of glycogen and decreased protein synthesis. So calcium is an important ingredient for the process of glycogen synthesis. So because of this inadequate presence of calcium, there will be loss of glycogen, and ultimately glycogen, which is important in the protein synthesis, is being inadequate. So this will also have an effect on decreased protein synthesis. Proteins, which are the building blocks of the human body, so these contribute to the major part of the cytoskeleton. Because of the decrease in the protein synthesis, there will be decrease in the functioning system of the cytoskeleton. Thereby there will be ultimately loss of the ultrastructural features, which could be at the cellular level or otherwise at the tissue level. Coming to the consequences of the membrane damage, when there is any injury and this injury starts affecting the membrane damage, so these are the processes which have been identified by based on certain studies, and come to a conclusion that when there is a mitochondrial membrane damage, then this mitochondrial membrane damage, since mitochondria serve as a cell membrane which has a permeability function, and this permeability function is being maintained by certain proteins. So these proteins, when they are damaged, this mitochondrial membrane permeability becomes compromised. That is, so by which the pores present in the mitochondria can be opened. So the mitochondria pores, which when they are opened, the mitochondrial contents, that is ATP or the cytochrome C or the contents proteins whichever are present within the mitochondria, they start leaking through this pore. Ultimately by this there will be decrease in the ATP production. So by which, when the energy is decreased and when the proteins have been completely lost from the mitochondria, this mitochondria is of no use, so it undergoes a death known as apoptotic death, where an unwanted cell is being removed by a process of apoptosis. Then the other form of membrane damage is the plasma membrane damage, where we see that the plasma membrane, which is a bilayered lipid membrane which serves in maintaining the osmotic balance. So because of the compromised membrane permeability in this plasma membrane, there will be loss of the osmotic balance, that is movement of the molecules from a lower concentration to a higher solute through this semi-permeable membrane. This function will be lost, thereby there will be no balance maintained between the two solutes. So thereby the cells, they may leak metabolites which are important for the construction of the ATP. Thereby there will be this loss of ATP results in depleting energy stores, that is the energy level will be decreased in the human body. Coming to the injury because of the lysosomal membrane damage. So lysosomes, as it is a membrane bound structure which contains the hydrolytic enzymes. These enzymes have usually serve in functioning of the removal of the cell debris and otherwise the unwanted or the waste which has to be removed from the body or which is harmful to the body has to be removed. So these enzymes, hydrolytic enzymes which are present in the lysosomes, become affected when there is any damage to this lysosomal cell organelle. So when there is any damage to this lysosomal membrane, these enzymes are released into the cytoplasm and they get activated. Once they get activated, they serve the function of digestion of the DNA, proteins or otherwise glycogen or even RNA. So thereby there will be decrease in the levels of the proteins and the DNA levels and the glycogen level, which causes which leads into a position known as necrosis, that is, which is a death caused by the enzymatic digestion. So coming to the chemical injury or otherwise known as toxic injury, so it is a more frequent and a major limitation to the drug therapy, and liver is found to be the target organ because most of the drugs, they get detoxified in the liver, so liver is seen to be the target organ for the chemical injury to occur. So there have been two mechanisms where chemicals start inducing cell injury. The first mechanism where the chemicals can injure the cells directly by combining with the critical membrane components, that is say about a chemical which has an affinity to a protein which is present in the cell membrane can bind to it and show its toxic effect by inducing within the cell, that is moving into the cell. So an illustration of mercury chloride poisoning can be given, which usually gets affinity to the proteins which are present on the membrane. It binds to them, it reaches the inner, it moves to the inner part of the cell organelle and causes a damage to the ATP, that is, it disturbs the ATP present within the energy, by ultimately there will be decreased in the energy content in the body. And the other illustration can be given methanol, which is usually used in certain industries and even in labs, where we find that methanol, once being reaching the body, it gets detoxified in the liver into a toxic formaldehyde or formic acid which is harmful to our body. So the other mechanism which is causes chemical injury is because of the toxic chemicals which do not have a direct effect, but they turn into the metabolites or the compounds which show a reactive toxic effect by converting into possible metabolites. So an example of acetaminophen can be given, which is an analgesic which is being used. The same procedure where its detoxification in the liver makes the liver toxic to its toxic substances. Coming to the ischemic and hypoxic injury, it's a type of most important and most critical injury where it could even lead to the death of a human being. Starting with the hypoxic injury. Hypoxic injury means hypoxia is a term which refers to reduced oxygen availability in the body. That is, there will be decrease in the oxygen tension or a decrease in the oxygen which is flowing along the blood flow in the body. There will be this state or this condition is known as hypoxia. Whereas ischemia is a condition, it is also a state where there will be decreased supply in the oxygen in our body, but this decreased supply in the oxygen is associated with the decrease in the blood flow. This decreased blood flow could be because of the obstruction in the arterial system. It could be because of a thrombi or emboli which blocks the arterial system, thereby blocks the blood flow, and thereby ultimately results in a reduced oxygen supply to the tissues. So ischemic tissue, it shows a compromised blood flow. Thereby, this ischemia, it also affects certain other processes like it compromises the aerobic metabolism. Aerobic metabolism is a function of a body system where it produces ATP with the help of, in the presence of oxygen. So this process of ATP production in the presence of oxygen, this becomes compromised because of, as ischemia shows a condition of decreased oxygen supply. So because of this decreased oxygen supply, there will be decreased aerobic metabolism, or it could be a compromised function. And because of this, there will be inhibited anaerobic energy generation. So anaerobic energy generation is a procedure or a function which only functions, it shows its function only for short bursts, that is during exercise period or something like that, where there is increased energy being utilized by certain functioning system or certain exercises, where there will be energy being produced with the help of, in the absence of oxygen. So this process will also be inhibited because of this ischemic tissues. And there will be exhausted glycolytic substrates. That is, glycolysis is a process where glycogen, that is glycolysis, the term itself describes glycogen, that is glycogen will be broken down, lysis, that is broken down. This glycogen will be broken down and this glycogen will be converted into ATP. So there will be inhibition of this glycolysis process, that is the glycolysis process won't function because of the ischemic tissue injury, and thereby there will be glycolytic substances also, there will be exhausted, that is the already present glycolytic substrates, that is the ATP. They could be, they might finish their function, that is they might have reached their extent of, they might reach their maximum extent of function and they get exhausted. And so there will be accumulation of certain metabolites. Metabolites are molecular byproducts of certain metabolic reactions. They could be in the form of ions or molecules. So there will be accumulation of these metabolites only. So for this reason, ischemia tends to be more rapid and it might cause severe cell injury compared with that of hypoxia. So the major biochemical reactions which take place in an ischemic tissue is, first thing is there will be unmasking of the phosphatide groups. For these phosphatide groups, they are usually masked, which have been covered with the help of oxygen. These get, because of the lack of oxygen, they get unmasked. That is, they get exposed. Phosphatide groups, they start getting exposed. Once these are exposed, they start taking up, they promote the uptake and intercalation of water. That is, there will be intercalation of the water, that is reversible ingestion of the water will be done within the cell organelle, by which there will be swollen mitochondria. That is because of increased in the intake of the water, the mitochondrial cell organelle becomes swollen, by which ultimately there will be dilated. or an enlarged endoplasmic reticulum, markedly because of the dilated mitochondria or because of a swollen endoplasmic reticulum, there will be increase in the size of the entire cell, and thereby there will be, because of the, is this increase also attributes to the increase in the concentration of the sodium and chloride there, and also there will be attributed to the decrease in the concentration of the potassium, because potassium, there is no influx of the potassium into the cell organelle. So suppose if oxygen is being restored to this ischemic tissue, then all of these disturbances can be reversible. They can come back to the normal functioning system. Suppose the ischemia persists, then irreversible injury to the cell takes place. That is, necrosis starts takes up. So irreversible injury, that there will be severe mitochondrial swelling, that is which we have already seen in case of reversible injury, where there is mitochondrial swelling because of the increase in the uptake of water and increase in the chloride also. And then there will be extensive damage to the plasma membrane. As the mitochondria keeps bulging, the plasma membrane also keeps bulging to a limit that it may rupture in certain areas. That is, there will be damage to the plasma membrane. Then there will be lysosomal swelling. Lysosomal swelling, that is a lysosome which contain these membrane-bound vesicles. They contain the enzymes. So intake of fluid intake within these lysosomes also results in swelling of the lysosomes. Then there will be a large, within the mitochondrial matrix, we can see large flocculent as well as amorphous densities can be seen. That is, the ruptured molecules of these mitochondrial contents or the lysosomal contents can be seen within the mitochondrial matrix. And then ultimately there will be massive influx of the calcium and massive influx of the calcium if the ischemic zone is reperfused. That is, if it is being restored with the oxygen, then there will be massive influx of the calcium. Coming to the ischemia reperfusion injury. Suppose the reperfused tissues, they may sustain the loss of cells in addition to the cells which are being irreversibly damaged at the end of ischemia. So reperfusion injury is a state or a function which is usually actually the cells which have been damaged because of ischemia get restored by the increased oxygen availability. So during this increased oxygen availability, there is chances of the cells to be damaged because suddenly they get exposed to an increased oxygen availability from a position of lack of oxygen. So this is a damaging condition to the cells, ischemic cells, previously exposed ischemic cells. So restoration of the blood flow to the ischemic cells can promote the recovery of the cells if they are reversibly injured. Suppose in case of reversibly injured cells are exposed to this reperfusion, they can be complete damage. That is, these cells can undergo death. But whereas in case of reversibly injured cells, if there is reperfusion injury, that is restoration of blood flow with the sufficient amount of oxygen, they can be restored back to normal condition. So reperfusion injury, that is a mechanism. Certain mechanisms have been proposed in reperfusion injury. The first one is there will be decreased reactive oxygen species and decrease in the reactive nitrogen species. Reactive oxygen species are the metabolites or the byproducts of during the metabolism of oxygen, and similarly the reactive nitrogen species are also the derived metabolites from the nitric oxide. So these they usually they are released from the parenchymal endocrinal cells as well as the infiltrating leukocytes. So these, when they are decreased in the concentration, they may create a new damaging process for the initiated during the reoxygenation. That is, the oxygen supply which is being again supplying to the area, this area can be again further exposed to a new damage process because of the reactive oxygen species as well as the reactive nitrogen species. This is one of the mechanism of reperfusion injury. The other mechanism is when there is ischemia and ischemic injury and associated with inflammation, it releases certain molecules such as cytokines which are inflammatory mediators. Otherwise, the other inflammatory mediators could also be the adhesion molecules, and these molecules are majorly being released by the hypoxia parenchymal as well as the endothelial cells. That is the cells which have been exposed to reduced oxygen supply. These cells start releasing these inflammatory mediators, by which these inflammatory mediators usually have function of recruiting the circulating neutrophils to attract to a area where they are usually present. So by this, the tissue will be reperfused to a normal tissue. So the other mechanism is a complement system. As already discussed, explained about the complement system, it is a biological functioning system which helps in phagocytosis of the cellular debris or unwanted waste. This complement system activation may also contribute to the ischemia reperfusion injury. So there is a picture showing the differences between the irreversible cell injury and reversible cell injury. The first normal cell which undergoes irreversible cell injury can be seen where there will be cytoplasm swelling of the endoplasmic reticulum as well as the mitochondria, and there will be formation of membrane blebs. That is, there will be formation of blebs or outgrowths of the cell which usually are cut off. They get dissociated from the cell organelle and completely get get exposed to cell death by process of apoptosis or necrosis, or usually they get engulfed by the phagocytic cells which function or normal functioning system in our human body. So we can also see clumping of the chromatin, that is the chromatin starts condensing. Suppose this reversible injury is in a state that it can overcome this injurious stimuli by adaptive responses, it recovers. Suppose this injury is being in such a state that the cell cannot overcome these exposure of the stimuli, then it undergoes irreversible cell injury, where there will be myelin figures formed. Myelin figures are nothing but the plasma membrane derivatives which appear in a whole phospholipid masses. That is, they appear in circular form of phospholipid masses, usually derivatives of the plasma membrane. That is, a plasma membrane which has been damaged or which has been ruptured. So when there is damage to the plasma membrane, it results in the formation of it thereby disperses its structure. That is, it does not maintain its integrity, by which there will be release of this plasma membrane structures into ruptured forms, and that forms the myelin figures, and this appears in the form of whole phospholipid masses. That is, they appear in the circular form, that is whole. So this necrosis, such a cell which has been exposed to an irreversible cell injury undergoes necrosis. That is, enzymatic digestion of the cell organelles occurs in the form of necrosis. So coming to the necrosis procedure. So necrosis is being defined as a series of changes that accompany cell death, which are largely resulting from the degradative action of the enzymes on already lethally injured cells. That means when a cell is being affected, that is when there is lethal injury to a cell, that is when there is a harmful effect to the cell, there will be certain enzymes which get activated. These enzymes could be hydrolytic enzymes or otherwise many other enzymes which usually have a protective function in our body. These enzymes, they get activated. These enzymes actually have a function of degradation. That is, they degrade the organelles which are not supposed to be present in our body. They degrade these enzymes, degrade the cell organelles in such a way that it occurs in a series of changes. Thereby, this accompanies the cell death that results in a form of completely eradication of the unwanted cells in our body. So morphologically, when you see a necrotic area, you see at the molecular cell level, when you see this necrotic area, you see that there is presence of intracellular protein denaturation. That is the proteins, they get they are broken down into minute particles or molecules, and then there is also presence of enzymatic digestion of the injured cell particles can also be seen being digested by the enzymes. And so the enzymes digesting these cells are the lysosomes, which consists of hydrolytic enzymes, which can be more than 50 hydrolytic enzymes in each lysosomal cell organelle. So the cellular contents are digested and the host response can be seen. So there's a lot of gap between this digestion of the cellular contents and the response of the host. That is between the where the manifestation of the signs and clinical signs and symptoms in a human body. So this time lapse could be the reason why there will be no detectable changes in the cells. So only because of this time gap, there will be no changes which can be observed with a naked eye. So this gives an exact illustration of this particular situation can be given as a myocardial infarction, where we see usually the proteins, when there's any damage to the myocardial cell membrane or anything, the proteins or any stored structures present within the heart, they get released out into the cell, and these are being digested by the enzymes of the lysosomes, and thereby there will be cell death, that is heart attack, which there will be no signs and symptoms, but sudden death can be seen in such heart attack patients. Coming to the morphology, how the necrotic cell appears, it usually, when it is, since it is a pathology, we need to know the microscopic structures, how they appear when they are stained with a general and most commonly used hematoxylin and eosin stain. So when they are being stained with hematoxylin and eosin, they appear, usually there will be increased eosinophilia. That is, there will be increased in the pinkish color can be seen in this necrotic cells. This is because this as eosinophilia, that is hematoxylin and eosin stain, they are an basic acid as well as basic stain. Hematoxylin is a basic stain and eosin is an acid stain. So they have an affinity to the oppositely charged molecules or cell compositions. So eosin has an attraction or an affinity to basic structures, because since it is an acidic component, it has affinity to the basic structures. So since cytoplasm is a major content which is being present in a necrotic cell, and because of the digestion of the other cellular organelles and only presence of cytoplasm, there will be cytoplasm as a basic structure. It shows more affinity for the eosin. So it attracts more of eosin, it binds to more of eosin and appears eosinophilia. There will be increased eosinophilia. And there will be more of glassy homogeneous appearance than other normal cells. This glassy appearance is mostly because of the loss of glycogen, which makes the cell, which keeps the cell normally appearing, makes the cell appear glassy when there is loss of this substance. Then it gives a moth-eaten appearance of the cytoplasm, that is, the cytoplasm becomes empty completely, and there will be complete digestion of the other cellular organelles, and the cytoplasm appears vacuolated. So this gives a moth-eaten appearance to the cytoplasm. And the myelin figures, as already explained, so they are the whole phospholipid masses which are being derived from the damaged cell membranes. These dead cells are being replaced by this myelin figures. So the phospholipid precipitate, phospholipids which have been broken down into smaller particle size or smaller molecular size for easy removal from the body or easy elimination from the body, these particles are being phagocytosed, or they are further being degraded into more smaller molecules known as fatty acids. If the dead cells, they are persisting, that is, they are not removed by the phagocytic cells, then they undergo a process known as calcification. The calcification, the dead cells are being embedded with more of calcium and other mineral components, and resulting into a dystrophic calcification, or otherwise it could be a metastatic calcification, which will be discussed further. So on an electron microscopy, that is in a deeper view of a cellular level of a necrotic cell, these are the characteristics which can be seen. That is, this continues in the plasma membrane as well as in organelle membranes. That is, the cell organelles which are being covered by cell membrane or a plasma membrane, they'll be discontinued. That is, they'll be irregular form because of the ruptured plasma membranes in between, because of the injury or because of the digestion of the enzymes. And then there will be marked dilation of the mitochondria. That is, mitochondria starts increasing in size because of the increased uptake of water, and there will be large amorphous densities, and also there will be presence of intracytoplasmic myelin figures, as already explained, and amorphous debris, that is unnecessary, unwanted cellular debris, that is the leftovers of the enzymatic digestion process. And along with that, there will be fluffy material aggregates which represent the denatured proteins. That is, the proteins which have been broken down into smaller molecules. They are even present in the form of fluffy materials. Coming to the nuclear changes, which is the most important part of the necrotic cell, where we find the changes in a picture representation can be easily being explained. That is, the first picture showing the cells which are in the blue form, blue colored structures, they are the live cells. That is the nuclei with a normal morphology showing chromatin which is being in a thread-like form, which further condenses to become chromatids in a process of cell division. But whereas in a necrotic cell, we see that this nuclei which contains a chromatin, this chromatin gets condensed, that is it condenses, it thickens and becomes dense into a circular form. So this condensation of the chromatin in the nucleus is known as pycnosis. This pycnosis further results in karyohexosis. Karyohexosis is a condition where the nuclei, it breaks up into small fragments, that is nuclear material. We can see the darkly black stained structures, that is a nuclei. It starts breaking down into smaller fragments. This process is known as karyohexosis. So karyohexosis ultimately results into karyolysis, that is the karyolysis, that nuclei means denotes karyo, and lysis means completely degraded, completely lost, or completely broken down nuclei, that is nuclei is completely dissolved. This is a stages where the nuclear changes undergo. So coming to the pattern of tissue necrosis, there are various other patterns which we can see in our day-to-day life. That is, they are the morphological distinct pattern, as they may provide the clue for the underlying cause. That is, these are morphological pattern, as clinically we can view the necrosis. This necrosis provides a proper clue, that is a basic cause, why the reason for this type of necrosis to occur can be explained when we view it with the naked eye. So these are the 6 types of necrosis, that is the coagulative necrosis, liquefacting necrosis, gangrenous necrosis, caseous necrosis, fibrinoid necrosis, as well as fat necrosis. Coming to the coagulative necrosis, it is a type of necrosis where the architecture of the dead tissue, necrosis is a dead tissue, okay. So the dead tissue architecture will be preserved in case of coagulative necrosis, and this tissue is preserved in such a form that there will be firm texture for few days. This so since in a gross specimen we can properly see that this tissue is firm on touching. So this is majorly because of the injured denatures, okay. The injured denatures, which are the structural proteins which have been denatured, as well as the enzymes which block the proteolysis of the dead cells, provides this kind of architecture in case of coagulative necrosis. And the necrotic cells in the morphologically in coagulative necrosis can be identified microscopically. When you see a necrotic cell of coagulative necrosis, you see that there is phagocytosis of the cellular debris by the presence of leukocyte. Leukocyte cells can be seen in the area of the phagocytosis, that is in the area of the cell debris, and there will be digestion of the dead cells with the lysosomal enzymes. Same method as we have discussed in necrosis. And the coagulative necrotic area or localized area of coagulative necrosis can be called an infarct. Okay, this majorly seen ischemia, which causes the obstruction in a vessel. Ischemia, that is decreased blood flow associated with decreased in the oxygen supply because of an obstruction in a vessel. This is a proper illustration of a coagulative necrosis, because the term suggests coagulative, that is a blood clot or any substance which has been coagulated, which has formed a clot. So there is a structure showing a coagulative necrosis in kidney tissue. This can be called as an infarct, the white substance where the architecture, that is a normal morphological structure of a kidney, is being observed as it is. Coming to the next pattern of necrosis, that is a liquefactive necrosis, where there will be digestion of the dead cells, which results in transformation of the tissue into liquid viscous mass. Liquefactive, the name suggests liquid, that is there will be liquid mass, necrotic mass tissue will be in the form of liquid and it appears viscous. So the necrotic material, since it is in a liquid form, it appears creamy yellow because of the presence of dead leukocytes, which give an inflammatory appearance, and this inflammatory appearance might also result in a pus appearance also. So it is called as pus. So a proper example of a liquefactive necrosis can be given in focal bacterial or fungal infections, where we see that as a cell, that the bacterial infected area is being digested by the enzymes such as lysosomal enzymes, and it starts to discharge pus. That is an example of a liquefactive necrosis. And another type of illustration which can be given is the hypoxic death of the cells in the central nervous system, which often manifests as a liquefactive necrosis. So there is a picture showing the liquefactive necrosis in a brain tissue, which shows a pus-like material which is being discharged. As along with that, liquid viscous mass can also be seen, that appears in a brown color in this picture. Coming to the next pattern of the necrosis, that is the gangrenous necrosis. It is not a specific pattern of cell death, but since it is only a term which is being most commonly used in the clinical practice. So a proper example could be given. Since gangrene is a structure which is being most commonly affecting the legs, that is the lower limb. So a leg which diabetic foot can be given as an example. In a diabetic foot, usually we find there's loss of blood supply and there's a color change, that is, it appears as dark brown because of ischemic perfused tissue. So this can be given a proper example for a gangrenous tissue. The other illustration is a superimposed bacterial infection, that is a bacterial infection and could be overimposed, that is overlyingly there could be a gangrenous necrosis, and but underlyingly it is majorly because the cause is because of a bacterial infection. In such cases we call it as a wet gangrene. Coming to the caseous necrosis, as the name itself suggests, caseous means cheese-like. So most often it is seen in the foci of tuberculous infection, and microscopically when we observe, there will be a collection of fragmented or lyse cells, that is the cells which have been broken down by the enzymatic digestion, or otherwise the phagocytosed cells, that is the leftovers amorphous densities of the cell. They accumulate together and form a collection of fragmented or otherwise lyse cells, and they form amorphous granular debris, and they are enclosed within an inflammatory border. So an inflammatory border which may constitute an infiltrating leukocytes or polymorphonuclear neutrophils, they keep surrounding this collection of lysed or dead cells and give an appearance of a granuloma. This is what is caseous necrosis. So there is a picture showing the caseous necrosis in a lung tissue, where we can see a proper cheese-like, Swiss cheese-like pattern showing of a dead area. Coming to the fibrinoid necrosis, it is a special form of necrotic necrosis which is usually seen in case of immune reactions. So as a part of complement system, the antigen and the antibody complexes, they are the structures which are being mutually interact with each other, but when these structures are being damaged or where there is any defect in these structures and they do not properly function, but whereas they are being deposited in the arterial wall, they result in fibrinoid necrosis. That gives the name fibrinoid, that is fibrin-like necrosis. It appears as a fibrin-like necrosis, that is a network of thread form. So ultimately, coming to the how the dead cells, that is the necrotic cells, are being removed, it is by a process of phagocytosis. That is a phagocytic cell. It starts engulfing the debris. That is, it takes up the cell. It eats the debris, cell debris into it by the help of certain enzymes, phagocytic enzymes, which have a property of attracting the cellular debris towards these phagocytic cells. And certain morphological changes which are being undergone or undertaken by this phagocyte, that is formation of pseudopods. It forms a proper cellular extensions which envelops the cellular debris. Once the cellular debris is being attracted towards the phagocytic cell, and it gets enclosed within the cell and it is eaten up by the phagocyte, and thereby these phagocyte cells are eliminated. So another process is by the enzymatic digestion of the leukocytes. These enzymes being released by the lysosomal cells. If suppose, as already told, suppose the necrotic cells are not being removed, then they are completely calcified. And this calcification of a dead tissue is known as dystrophic calcification, where calcification occurs in a proper living tissue which appears otherwise normal, is known as metastatic calcification. So we'll be discussing what calcification is and what the types of calcification are. So usually calcification is the deposition of calcium in an abnormal sites, that is in the sites of cell death. Usually we see calcification when the dead cells are not being removed. These cells have a capacity to attract the calcium which is normally flowing in the blood, normally present in the body tissue in the normal level. This gets attracted to the dead cells and thereby it gets deposited, and then along with this calcium there will be other mineral salts which can also be deposited. So it forms into a calcification. So abnormal tissue deposition of calcium salts with smaller minor quantities of iron, magnesium and other minor salts is a process of calcification. There are two forms of calcification, that is the dystrophic calcification and the metastatic calcification. Dystrophic calcification is a calcification which occurs in dead and dying tissues, whereas metastatic calcification is a calcification which occurs in an otherwise normal tissue where there is when there is increased in the serum calcium level, that is in hypercalcemic conditions, we see this metastatic calcification. Coming to the dystrophic calcification, usually it is seen in the areas of necrosis, and the major example can be given atheromas or atherosclerosis, that is thrombi or emboli which are formed in the arterial blood valves, gives an example of dystrophic calcification. And another example can be given as aging or damaged heart valves, where they even help in hampering the further function of the heart, where they have a property of attracting for this calcification to occur in these damaged heart valves. So the process of pathogenesis, that is the formation of a calcification, is more important to know, because by eliminating the cause, we can even eliminate a further formation of calcification. So the process of calcification occurs in two phases, that is the initiation or the nucleation phase, that is the first phase, then is the propagation phase. In the initiation or nucleation phase, this occurs intracellularly or extracellular. Intracellularly, it occurs within the mitochondria. Extracellularly, it occurs within the external cell membrane, external to the cell membrane, where it occurs in the form of membrane-bound vesicles. So initially the calcium salts, they get deposited, they enclose themselves into a vesicles. It could be intracellularly also. When it occurs in the mitochondria, we see that the mitochondria starts excreting these membrane vesicles out from the mitochondria and discharges it into the cytoplasm. Whereas in extracellular initiation or nucleation phase, we find that the membrane-bound vesicles which are present within the cytoplasm, they attract this influx of the calcium within the vesicles, and they further hamper, that is, they further attract the more calcium as well as the other mineral salts in minor quantities within the vesicle. Once these membrane-bound vesicles in a proper matured form, they continue with the process of propagation. That is, the further growth of this vesicles occurs into a proper matured form, and this results into a crystalline calcium phosphate. This is the pathogenesis of calcification. So coming to the morphology, microscopically, that is a morphological view, that is a gross specimen of a calcification. It usually appears as fine white granules or clumps, which often on palpation can be felt as gritty deposits. So an example can be given of a tuberculous lymph node, which is essentially converted into a radio-opaque stone. So in a radiograph, when we see a tuberculous lymph node, usually it appears radiolucent, that is, it appears blackish or somewhat nearly black appearance. But in a when there is a calcified tuberculous lymph node, that is, it appears radio-opaque, it appears white in color, because the radiation which is being exposed to, it does not allow it to pass through it. So because of this, it blocks the radiation and it appears radio-opaque in color. So histologically, that is microscopically, when you view it under a microscope, you find it as a intracellular or a extracellularly. This calcification, whether it could be an intracellular calcification or an extracellular calcification, it shows basophilic as deposits. That is, it attracts the basophilic stain. That is, it attracts the hematoxylin stain and appears violet in color. So sometimes in the focus of calcification, which is too much mature or older in age, it gives an appearance of a heterotopic bone. That is a bone which is formed in an abnormal position. So this calcification can progress into a heterotopic bone. So metastatic calcification. So the calcification, as already defined, it is a calcification which occurs in an otherwise normal tissue. It is mainly because of an increase in the serum calcium level, that is known as hypercalcemia. So the four major causes of this hypercalcemia could be increased secretion of parathyroid hormone. Parathyroid hormone is a hormone which functions in production of the calcium directly or indirectly. So by this increased secretion of the parathyroid hormone from the parathyroid glands, there will be increased in the calcium levels in the blood. By which it might be one of the cause for the metastatic calcification. The other form is destruction of the bone. Bone, as we know, it consists of calcium. The calcium forms a proper bone weight along with the other bone cells. So this bone, when it is destroyed, that is, it is fractured, or otherwise it is being broken down into fragments because of any injury or any trauma, it releases calcium into the blood, by which there will also be increase in the calcium levels in the blood. The other form is vitamin D related disorders. Vitamin D is also a process where it is also involved in the production of the calcium in the blood serum levels, by which when there is any altered production of vitamin D, inadequate intake or vitamin D or anything, there will be hampered process of the calcium in the blood levels, by which it can also cause the metastatic calcification. The other one is renal failure. So renal failure is a condition where kidney failure, it means kidney failure, where kidney usually functions in absorption of calcium. So when there is a abnormal functioning system of the kidney, which results in which hampers, that is, it causes an altered absorption of the calcium. It might be that inadequate calcium might be absorbed, or it might not completely absorb calcium, because of which there will be increased in the calcium levels in the blood flow, by which there will be hypercalcemia, and ultimately there will be metastatic calcification. Coming to the morphological features, usually metastatic calcification, it widely occurs throughout the body, but principally it is most commonly seen in certain interstitial tissues like kidney, lungs, and the gastric mucosa are the structures which have more affinity for the metastatic calcification. Coming to the morphological resemblance, usually it similarly appears as a dystrophic calcification, that it appears as a fine gritty deposits or granules in the form of which appears white in color. Clinically, usually normally we do not find any dysfunction, but when there are extensive calcifications, usually in the form of extensive calcifications where we see in cases of lungs, there will be compromised respiratory functions can be seen, because since this calcified tissue forms an obstruction, it results in a compromised respiratory defects. So then next comes the massive deposits in the kidney. Usually when you see massive kidneys, that is in the renal tubules or otherwise in the glomerular nephritis or any area in the kidney, part of the kidney, when there is metastatic calcification, it forms an obstruction, finally causes the damage of the kidney. So this completes the calcification process. Further we'll be discussing about the apoptosis. Apoptosis, which is known as a simple word termed as programmed cell death. This programmed cell death is usually a tightly regulated suicidal program where the cell it activates its own nuclear nuclear DNA and nuclear cytoplasmic proteins in such a way that they help these cells which are destined to die to reach to a stage of death. So the proper definition says like this: it is a pathway of cell death which is induced by a tightly regulated suicide program in which the cells destined to die activate enzymes that degrade the cell's own nuclear DNA and the nuclear as well as the cytoplasmic proteins. So it was previously coined as programmed cell death, but later based on certain investigations it has been coined as apoptosis. So it is a unique mechanism. It is distinct from necrosis. Necrosis is a proper kind of cell death because of a lethal injury, but apoptosis is not because of an injury, but it is because it is a kind of protective function where unwanted cells or cells which have already purposed the function of purpose their complete function and cannot anymore function, that their cells which are completely exhausted in functioning are removed by the process of apoptosis. So the differences between necrosis and apoptosis are as follows. In necrosis, we have seen there is damage, that is, there is severe damage to the membrane, and Because of this severe damage, there will be enzymes, lysosomal enzymes, which will be released out of these lysosomal organelles, which enter into the cytoplasm. They cause the cellular digestion. So this cellular digestion will cause the leaks the cellular contents outside, out of the cell, and then whereby necrosis happens. Necrotic cells are removed by the process of phagocytosis. Whereas in apoptosis, where we see when the damage is beyond the repair, that is when there is an irreversible damage to any cell, when there is an irreversible damage, that is to a cell's DNA or otherwise proteins or any kind of cell organelles, then there will be this cell starts showing the apoptotic mechanism. That is enzymes which degrade the cell's nuclear DNA or the cytoplasmic or the nuclear protein. They get activated and they cause dissolution of the nucleus. That is, the nucleus starts dissoluting. That is it. The cell starts completely shrinking in size. Whereas in necrosis, we have seen that there's swelling of the cell, but in apoptosis, there is shrinkage. That is reduction in the size of the cell. Then once there is reduction in the size of the cell gets fragmented. That is, it breaks down into smaller particles without any loss of the membrane integrity. Whereas with necrosis, where we see there is loss of the membrane integrity completely. So, but here we see there is proper maintenance of the membrane integrity, and this membrane integrity helps in formation of membrane blebs. That is unwanted waste. They get formed into a proper oval structures which get separated from the cell organelle, and they get discharged and they are removed, which contain the cellular debris. They are detached from the cell, and further by the process of apoptosis they have been completely eliminated from the body. This is the process of brief introduction of the process of apoptosis and the major difference with the necrosis. So coming to the in detail differences between the necrosis and apoptosis, coming to the cell size, we see cell swelling, that is enlargement of the cell in necrosis, whereas in apoptosis we see there is decrease in the size, that is cell shrinkage can be seen. In nucleus, the differences, we see that is a pycnosis, that is a condensation of the chromatin. Then we see the karyohexis, that is the breakdown of the nucleus. Then karyolysis, that is the complete dissolution of the nucleus can be seen in case of necrosis, whereas in apoptosis we see that the nucleus is being broken down, fragmented into nucleosome size fragments. So in plasma membrane, coming to the difference between the necrosis and apoptosis and plasma membrane, the plasma membrane is being disrupted, completely damaged, whereas in apoptosis we see that there's an intact plasma membrane. Coming to the cellular contents in necrosis, we see that the enzymatic digestion because of the lysosomal enzymes, ultimately because of the digestion of the cellular contents, there will be leakage of the cellular contents out of the cell. But whereas in apoptosis, we see that cellular contents are intact, but it could be possible by the formation of the cell membrane blebs. These membrane blebs, which are cut off from the leftover cell body, they have become as apoptotic bodies, and which are that means they make up the further function of phagocytosis into ease. That is simplify the process of phagocytation by forming apoptotic bodies. And coming to the adjacent inflammatory structures or presence of any inflammation, usually we see in necrotic cell that once we see in microscopically that we have seen that the cellular contents and the cellular debris they form large amorphous densities in a collective, which are being, that is the cellular debris and the infiltrating leukocytes. They get there's a collection of these cells into large amorphous densities, which are being surrounded by inflammatory cells, that is a polymorphonuclear neutrophils or otherwise any further inflammatory mediators or inflammatory cells. So there will be frequent presence of adjacent inflammation surrounding a necrotic cell, but whereas in apoptosis there is no such inflammation. So this is a major difference between the necrosis and the apoptosis on viewing microscopically. So coming to the physiological or otherwise the pathologic role of necrosis and apoptosis is that in necrosis usually we find that there's invariable pathological, so it is a form of major function of necrosis is a pathological form of necrosis. That is, it usually occurs when there's irreversible cell injury in the body, whereas apoptosis functions as physiologic as well as pathologic. Physiologic by eliminating by unwanted cells or the cells which have reached into an exhausted level, and in pathologic forms where the cells which cannot be which have undergone irreversible injury and which cannot be restored to proper functioning system, these cells are being removed. So apoptosis has its function in physiologic conditions as well as in pathologic conditions, whereas necrosis has its functioning only in the pathological conditions. So coming to the picture representation, the differences between necrosis and apoptosis, where we see the normal cell structure showing presence of nucleus and other cell organelles and the proper cell membrane, where we see in necrosis that the membrane becomes irregular, and subsequently there is a there's the disruption of the membrane as well as there is increase in the size of the cell in the necrotic cell. Along with that, the cell organelles are being digested in case of necrosis, and ultimately the cell membrane becomes structured and the cellular contents are being leaked out. Whereas in apoptosis, we see that there's formation of membrane blebs, small blebs. These membrane blebs, they grow into size, they get cut, they are cut down from the cells, they form separate apoptotic bodies, which are further phagocytosed. So there is a picture representation showing the differences between cellular level differences between the process of necrosis and apoptosis. So coming to the causes of apoptosis. So apoptosis, it occurs in physiological conditions as well as in pathological conditions. Coming to the physiological conditions, usually we see that in embryogenesis, say for example, usually our toes and fingers, in a developing embryo, there's no any difference, there's no any gap between the developing toes and embryos in a developing embryo. But because of the process of apoptosis, there'll be division between these fingers and toes by the function of by the process of apoptosis. That is, these unwanted cells which are present between, which are attaching cells, that is the cells which connect the adjacent fingers, are being eaten up or being removed by process known as apoptosis, and which usually make our fingers to be separated and our toes appear separated because of the process of apoptosis. So this is an illustration during the physiological function of apoptosis during embryogenesis. And the other function is cell loss in proliferating cell populations. When the human has increased number of cells, or the cells which are not required in number are being removed by process of apoptosis. These unwanted cells can be removed. Then the presence of self-reactive lymphocytes, that is the lymphocytes which are supposed to be harmful to our bodies, are being eliminated by process of apoptosis, which is also a physiological function of apoptosis. Coming to the death of the host cells that have served their useful purpose, that is the cells which have functioned to a maximum limit, which have no more required in the body, are being removed by process of apoptosis in physiological situations. So apoptosis in case of pathological conditions, usually we see in case of DNA damage or irradiation, or because of any cytotoxic anti-cancer drugs, or any hypoxic conditions, or presence of accumulation of misfolded proteins, or presence of certain infections. So these are the conditions which usually create a situation, or which usually create an atmosphere for cell that it cannot revert back to its normal function. It cannot be reversed to its normal function in spite of its adaptive responses. So in such conditions, usually apoptosis occurs. So these conditions are said to be the pathological situations where the apoptosis is supposed to be taken, and it is compulsion that these cells, that is the damaged DNA or the cytotoxic drugs which are creating harmful atmosphere to the surrounding, to liver where it is being detoxified, or the kidney where it is being excreted. So any radiation exposure to any cells which could be a cause of further damage to the cells by hampering the normal function of the cell, or otherwise hypoxia, that is the decreased oxygen availability to a cell, that is the cell cannot survive anymore because of the lack of oxygen. And all these conditions, accumulation of misfolded proteins. Misfolding proteins can also take up an abnormal genetic information by which there will be abnormal production of further proteins. So all these factors could be could be very harmful to our human body by creating further progression of the disease. So these are supposed to be removed or eliminated from our body. This occurs by a process of apoptosis. So in certain infections, like say in viral infections, usually a virus, when it gets integrated with, that is when it starts starts getting inserted into a human body. Usually a virus does not show its effect when it's present extracellularly. It only can show its proper effect. It only can infect a person when it is integrated within the cell organelles and present within the nucleus, where it can affect the DNA by disrupting the DNA structure, or replacing its structure with the DNA, that is a viral genome, by forming viral genome. Only then it can show its function, virus. So in such cases, in such viral infection, certain viruses, they induce themselves to apoptosis, or otherwise because of p53 like structures, that is tumor suppressor genes. This gene also activates the apoptotic factors, which initiate the process of apoptosis in infections. So coming to the morphological and biochemical changes in the process of apoptosis, usually we see cell shrinkage, that is the size of the cell, the cell which is being affected decreases in the cell, decreases in size, and then comes the chromatin condensation. This chromatin condensation means that is chromatin starts thickening, that is it condenses. It thickens in such a form that it completely forms like a clumps together. Then there will be formation of cytoplasmic blebs, that is the cellular debris or the cell organelles. They get accumulated into these cytoplasmic blebs, and they are cut off from the responding cell. So these blebs which have been detached from the remaining cellular part, these blebs are further known as apoptotic bodies. These apoptotic bodies are further phagocytosed by the phagocytotic cells. So there is a picture showing the normal cell with the normal nucleus and the cytoplasmic organelles. We can see the endoplasmic reticulum, Golgi apparatus, ribosomes, mitochondria, and vacuoles which are being present. In the next picture, where we see that the nucleus showing the condensation, that is there will be cytokinesis. That is it will be breakdown of the chromatin part or the cellular part, and there will be shrinkage of the cell, that is the decrease in the size of the cell, and accumulation of the cellular debris and the cell organelles into the blebs which have been formed by the cell membrane, and then these blebs which are being separated from the cell body and forming the apoptotic body, and they enter into the phagocytic process, where the phagocyte, it forms the phagocytic cell. It is forming the pseudopods, that is the extensions of the cell membrane, so that it can completely envelop the cellular debris and engulf it, that it can eat up the cell more appropriately. So this is a process of apoptosis. Histologically, since this is a pathology, it is very much important to know the microscopic features, what can be observed in an apoptotic cell. So the arrow which is showing at the bottom, we can see that it is completely eosinophilic, that is it has taken up more of pinkish color, the stain which is appearing as a blue here, but it is a stain which is showing cytoplasmic vacuolation can be seen, that is a moth-eaten appearance can be seen. And the arrow just above it on the right side can be seen, that is as chromatin condensation can be seen, and the remaining arrows, that is similarly we can see that is increased eosinophilia and the chromatin condensation, that is cell organelles which have been completely disorganized and the cytoplasm being occupied in the entire cell. So coming to the process of apoptosis in detail, usually it is because of the major enzymes known as caspases. These caspases are, if we split the caspase, that is Ca, if we split the word caspase into two words, that is C and aspase. C is the cysteine part and aspase is the aspartic acid residue. So C is a cysteine part which helps in binding this enzyme to the aspartic acid residue. That is, the aspartic acid residue is a binding site for this enzyme to be bound. So we usually find apoptosis in two phases, that is the initiation phase and the execution phase. So caspases are similarly divided into these two phases, that is the initiator phase caspases are the caspases 8 and 9, whereas the execution phase caspases are 3, 6 and 7. So the initiation process of apoptosis is being divided into two phases. Initiation phase, where the caspases become catalytically active, they become active, and the execution phase, the caspases, they trigger the degradation of the cellular contents, that is the contents, cellular organelles or the cell composition which is supposed to be eliminated. These are being degenerated by the execution caspases. Coming into the process, it occurs majorly because of principally by signals from two distinct pathways, that is because of two pathways. Intrinsic pathway, also known as mitochondrial pathway, since it occurs in mitochondria, and extrinsic pathway, since it occurs in a receptor area, it is concerned with initiated by the receptors, it is known as death receptor initiated pathway. So both these pathways, that is the intrinsic pathway and extrinsic pathway, ultimately finally they both converge and cause the activation of the execution pathway, that is the final pathway of the apoptosis. So there is a picture showing this is a picture showing the mitochondrial pathway of apoptosis, where we can see the differences between the normal cell, that the proper viable cell which functions normally, and between the apoptosis. So the picture in the first picture, where we see survival signal in the form of growth factor comes and transmits its signal to the intercellular with the help of a receptor which is present in this cell membrane. So these signals are transmitted internally into the cytoplasm. From the cytoplasm, within the cytoplasm, there are present certain proteins which are involved in apoptosis. There are two types of proteins which are present. One is the anti-apoptotic proteins and the other one is the pro-apoptotic proteins. So anti-apoptotic proteins, they are the BCL2 or BCLX. These proteins, they usually prevent the process of apoptosis from happening. So they are kind of proteins which hinder the process of apoptosis. Suppose apoptosis is not supposed to be done, then these proteins, anti-apoptotic proteins, they get activated and then further prevent the process of apoptosis to happen. Whereas when the apoptosis is supposed to be happen, when the cell is definitely has to be removed out from the body, then the pro-apoptotic proteins, pro-apoptotic means the pro, that is they promote the apoptosis. So that is they initiate the process of apoptosis. These proteins get activated. So they could be BIT, BAX or BIM. These are the pro-apoptotic proteins which activate the process of apoptosis, and BCL2 and BCLX proteins are proteins which prevent the process of apoptosis, means anti-apoptotic, against to apoptosis. So like that, once the signals are being transmitted intracellularly, that is they reach the cytoplasm, there will be production of anti-apoptotic proteins within a healthy normal functioning cell. So these proteins, BCL2, usually they get activated by these signals, and usually in a mitochondria there is a channel known as Bax channel. That is Bax channel. This Bax channel is a channel which usually maintains the cell permeability. That is the pores which usually function in production of the ATP. These pores are being closed with the help of this Bax channel. This Bax channel, so since it prevents the unnecessary ATP or proteins to move out of the cell organelle like mitochondria, this Bax protein, it thereby maintains the permeability. It's a kind of protecting function to the mitochondria. This protecting function thereby gets activated, and the cytochrome C, which is present within the mitochondria, because of the signals which are being produced from this growth factor, when they reach the mitochondria, they activate the Bax channel. That is, they inactivate this Bax channel. That is, they do not promote the activation of the Bax channel. Thereby, they do not open the pores. So by this, there is no loss of cytochrome C, and thereby there is no leakage of any mitochondrial contents usually in a viable cell, that is a normal functioning cell. But whereas in an apoptotic cell, that is a cell which is supposed to undergo cell death. In that cell, we see that there is a lack of survival signal. In spite of lack of survival signals, when there's any DNA damage or any exposure to radiation, this causes the activation of the cytoplasmic proteins or the sensors, which are known as BH3 proteins. They are antagonists, that is, they act against the BCL proteins, BCL2 proteins. BCL2 proteins, as I have told, they are anti-apoptotic proteins. They prevent the process of apoptosis to happen. So this BH3 proteins, they act against the anti-apoptotic proteins. That is, they function opposite. So once when there is any irradiation, there is DNA damage. When the signals are being sent in spite of lack of any growth factors or any signaling factors, there will be damage to the DNA. Once there is damage to the DNA, there will be activation of sensors. That is, these sensors constitute the BH3 proteins. These proteins, they act against the BCL2 proteins, that is the anti-apoptotic proteins, which usually control the process of apoptosis. So they act that means they act against the BCL2 proteins, means they promote the process of apoptosis. They initiate the process of apoptosis. For the promotion of apoptosis, that is to initiate the process of apoptosis, there should be activation of this back channel. This back channel, as explained, it is a channel which protects the membrane permeability of the mitochondria. That is, it covers the pores, it closes the pores which are not necessary when needed. But still, this gets activated because of the radiation which is being produced and because of the BH3 proteins, and thereby once this is being activated, that means the pores in the mitochondria, they get open. They create a channel by which the unnecessary removal of the cytochrome C is being removed from the mitochondria. Once the cytochrome C is being removed, and that is when there is leakage of the cytochrome C through this back channel protein or the mitochondrial pores, there will be activation of the caspases, that is the enzymes which promote the process of apoptosis. This explains the mitochondrial pathway or the intrinsic pathway. Coming to the extrinsic pathway, that is the death receptor initiated pathway of apoptosis. Usually we see that it occurs with the help of fast ligand. Ligand is an ion or molecule which once when it binds to the receptor, it activates the receptor and proceeds the further functioning of the signaling process. So usually when an inactivated fast receptor is present and it binds to the intracellular death domain. Death domain is also a kind of cell receptor or a cell signals which when binds to the survival signal, it initiates the process of transmitting of signal. So we see that when a fast receptor is binding to a death domain, there is no activation of signal, there is no transmission of cell signal. So this process requires the presence of ligand. So fast is a ligand, that is apoptosis stimulating fragment ligand. When this ligand, it binds to the death receptor, that is the death domain which is present intracellularly. These both get activated and the signals, they pass intracellularly, and these signals together, they form the fast associated via death domain. This fast associated via death domain is a structure which constitutes of apoptosis simulating fragment as well as a death domain, which helps in binding of the signals and thereby transmitting the signals for the process of apoptosis. These two bind together and form a fast associated via the death domain, and they cause the activation of the procaspase 8. And this procaspase 8 is a structure which is an inactivated caspase 8. So once this procaspase 8 is being activated with the fast associated via death domain, these procaspase 8, they usually 4-5 structures of these 4 procaspase 8, they bind together and form the active caspase. That is, they cause the activation of the caspase by when these procaspase 8 bundle of them bind together and they initiate the process of apoptosis. This constitutes the extrinsic death receptor initiated pathway of apoptosis. So these both pathways, that is the intrinsic pathway and the extrinsic pathway, that is the mitochondrial pathway and the death receptor initiated pathway, together they activate the cascade activation, which initiates the process of execution or the final phase of apoptosis. So this is a picture which is this is the picture showing the mechanism of apoptosis, which shows the mitochondrial pathway as well as the death receptor pathway. So in presence of cell injury or any growth factor or because of any DNA damage or otherwise any radiation or free radical, that is reactive oxygen species which are dangerous to the human body, or presence of any misfolding protein which causes endoplasmic reticulum stress, which cannot be reverted, which cannot be restored to the normal function. These act as a signaling factors which once get attached to the receptor present on the cell membrane, these signals are transmitted intracellular. When these signals are being transmitted intracellularly in an intrinsic pathway, there will be activation of the BCL2 proteins. These BCL2 proteins are the anti-apoptotic proteins. So once the BCL2 proteins, that is the anti-apoptotic proteins which control the function of apoptosis, are being activated because of these signals which are being transmitted by any injury or irradiation or DNA damage or misfolded protein or lack of withdrawal of the growth factor signals. So these proteins, they cause the BCL2 family effectors, that is the BAX as well as BAX, that is they cause the activation of this BAX or BAX channels, which usually maintain the mitochondrial membrane permeability, to become compromised, and this compromised function of this BAX and BAX channel causes the opening of the mitochondrial pores by which the cytochrome C is being released. This cytochrome C is involved in the activation of the initiator caspases, or otherwise it can even mitochondria which also constitutes the pro-apoptotic proteins. It can also cause the activation of the executioner caspases when they are released because of the opening of this BAX channel. So once there is opening in this happens in the mitochondrial or intrinsic phase, that is the cytochrome C as well as the pro-apoptotic proteins, they are being released because of the compromised function of the BAX channel, which is because of the activation of the BCL2 anti-apoptotic protein activation. This occurs in the intrinsic pathway, whereas in the extrinsic pathway, activation binding of a ligand to a receptor is being results in an activation of adapter proteins. These adapter proteins have a function in activating the initiator caspases. This initiator caspases, as we have seen, both the mitochondrial and the mitochondrial as well as the death receptor initiated pathway together, they cause the activation of the execution pathway, which can be seen together. They cause the activation of this execution pathway. This execution pathway is involved in activation of endonucleases. Endonucleases are the enzymes which are involved in fragmenting the DNA. That is, they split the DNA, double-stranded DNA, deoxyribonucleic acid strand, which is composed of a double-stranded structure which is bound with the help of hydrogen bonding. This endonucleases show its effect on the hydrogen bonds by which the DNA strands, they get separated from each other, and further they are fragmented into smaller sizes with the help of DNase enzyme and other respective enzymes, and simultaneously the DNA fragmentation occurs, as well as there will be breakdown of the cytoskeleton. That is the cytoskeleton structure which is the backbone of the cell. This is also being disrupted. That is, it gets degenerated because of these execution phase caspases. By this, once the degradation of the cell organelles and the other cytoskeleton structures, then this results in the formation of bleb. Cytoplasmic bleb forms. In this cytoplasmic bleb, the cells, unwanted cellular organelles and cellular debris, they get accumulated, and this cytoplasmic bleb, it gets detached from the remaining cell organelle and it forms an apoptotic body. This apoptotic body, we can see that with the help of ligands and the phagocytic cell receptors, they get attracted to the phagocytes with the help of certain phagocytic respective enzymes, and they are being phagocytosed. That is, they are being engulfed within the phagocytic cell. This completes a complete process of apoptosis. So active form of initiator caspase is a main reason for resulting into a enzyme death program, which is being mediated by the activation of the execution caspases. So giving an example, once the caspases are being activated, say suppose in DNA fragmentation, the activated caspases, they cause the they cleave the inhibitor of the cytoplasmic DNAs, which is an enzyme which maintains the structure of the DNA double helical strand. So this activated caspases, they compromise the function of this DNAs, which is usually supposed to maintain the structure of the DNA, but is being compromised because of the activation of caspases. So by this, the DNA becomes enzymatically active, and it starts causing the cleavage. That is, it starts disrupting the double-stranded DNA bond. It separates the DNA strands into two separate strands, and then they are further being fragmented into nucleosome-sized pieces. So which is being easy for the phagocytosis process to be undertaken. So there is a process of apoptosis. So once the dead cells are being removed, that is the dead cells which have to be removed, that is the apoptotic bodies, they are being removed by forming into bite-sized fragments. That is, they are being broken down into such smaller particles that they should be edible for the process of phagocytosis for the phagocytes. And so the changes by the apoptotic cells and their fragments, they usually actively promote the process of phagocytosis. So this is the reason that the before the secondary necrosis is being attempted, these fragmented cells and the apoptotic cells are being completely removed from the organs. So coming to the defective, any abnormalities in the process of apoptosis. So the abnormalities could be defective apoptosis, that is inadequate apoptosis being going on, and because of what, there's increased cells available within the body, or otherwise it could also be increased apoptosis of increased cell death can also be seen. So these are the two situations or two conditions that we see in case of defective apoptosis. So usually when there is a the abnormal cell survival, it is because of the defect in the apoptosis process, because of any inactivation or activation of the pro-apoptotic or the anti-apoptotic proteins might result in the permits, which might permit the survival of the abnormal cells. It is also because of the p53 mutations. p53 gene, which serves a major function in protecting the human body from unwanted tumors to be grown there. So it is known as tumor suppressor gene. It is p53 gene is a tumor suppressor gene which usually has a function in promoting the process of apoptosis. So whereas in any mutations, that is any abnormal changes in this p53 gene, there will be inactivation of the process of apoptosis, where it does not let the apoptosis to happen and lets the survival of the abnormal cells within the body, and thereby which might complicate the further process. And that is the potentially harmful cells. As we have seen that the toxic or harmful self-reactive lymphocytic cells, which are supposed to be removed of the body, when they are present within the body, they are being very harmful to our body by hindering the processes and increasing the process of phagocytosis or further cell death processes. So they might also affect the process of inflammation, which are usually associated. So this happens in defective apoptosis. So when there's increased apoptosis can be seen in certain conditions like neurodegenerative diseases, that is when there's any degeneration happening in a disease such as a nerve concerned with the nervous system, then there'll be increased apoptosis, there'll be increased cell death will be happening. So, and even there'll be in ischemic injury also, we see that there is increased apoptosis. That is when the tissue is being a lack of any oxygen supply or decreased blood flow because of any obstruction in the arterial system, those cells are exposed to apoptosis. So if this ischemic injury is not being restored to normal, there will be increased number of cells which will be undergoing cell death. Ultimately there will be increased apoptosis. In viral infection, we have seen that there are certain viral infections which induce the process of apoptosis, that they themselves promote the apoptosis process. That is, in cases of HIV, HIV process, where there will be, since there is decrease in the CD plus 4 lymphocytes, so there will be decrease in the immunity system. So this decrease in the immunity system will indirectly result in increased apoptosis. That is, since the cells get weakened day by day and they do not function the proper function up to the expected extent, so they are being removed by the process of apoptosis. So this finishes the mechanism of apoptosis. Coming to autophagy. Autophagy is a process where there will be cells which will be eating up their own cellular contents. The autophagy, which means self-phagy means eating up. So this is a process which happens in autophagy. Whereas in heterophagy, cells eat up the vesicles or fragments which are being promoted, which are being reached to the cell from extracellular. So cells taking up the extracellular contents into the intracellularly. So that is heterophagy. So these autophagy and heterophagy are a kind of survival mechanisms when there is presence of nutrient deprivation, when the cells are otherwise being starved. So they recycle their own material, that is the digested contents. Already utilized contents are being recycled, that is, they are being processed into a form that so that they can be further used, again to be utilized by the cells. So that is the process of autophagy. So on autophagy, when there is any lack of nutrients, that is, there is lack of nourishment to the cell, they eat up their own fragments, that they have their own contents so that they can get nourishment from their own cell organelles. So there is the process of autophagy, and this is being mediated by certain genes known as autophagy genes. They are being denoted by ATGS. So there is a process which can be seen in autophagy. Firstly, there will be sequestration of the intracellular organelles and portions of the cytosol. That is, there will be separation of these organelles which are present within the cytoplasm as well as the cytosol. That is, the liquid portion of the, or the clear portion of the cytoplasm is known as cytosol, whereas the whereas the portion of the cytoplasm which contains numerous organelles or increased concentration of organelles is known as cortex of the cytoplasm. So there will be sequestration of the intracellular organelles as well as the cytosol. This will cause the autophagic vacuole. That is, autophagic vacuole is a membrane-bound vesicle form which consists of cell organelles as well as the cytosol within it. That is a eaten up form of a cell. That is a oval structure which contains cell organelles and cytosol within it. This autophagic vacuole, it fuses with the lysosomes. Lysosomes, which are nothing but cell-bound membrane organelles which contains hydrolytic enzymes. So once this autophagic vacuole fuses with this lysosome, it results in the formation of autophagolysosome. That means it forms into a structure which consists of enzymes which cause the digestion of the cellular contents as well as the digested cell organelles and the cytosol portion of the cytoplasm. These all of them constitute together in the autophagolysosome. So since there is a presence of lysosomes within this autophagolysosomes, these lysosomes will be released and they digest the already present cellular components within this autophagolysosome. So this is a sequence or the pathogenesis which happens in autophagy. So there is a picture representation showing the differences between autophagy as well as heterophagy. So the organelles which are being present in the autophagy, that is the first picture showing the smooth endoplasmic reticulum, the mitochondria, which are being taken up by the cell itself. That is, they form the primary lysosome, then they result in the autophagic vacuole. Once they take up all the cell organelles, that is the endoplasmic reticulum and the mitochondria can be seen within the autophagic vacuole. This autophagic vacuole increases in size. It fuses with the lysosome and results in the formation of digestion of the cellular components because of the lysosomal process. So by which this completes the process of autophagy. Whereas in heterophagy, we see that the primary there has been particle, that is the particle, the ingested particle is from the extracellular. It is not concerned with the intracellular or any cytoplasmic organelles, whereas it is completely with the external stimuli. So the ingested particle contains reached within intracellularly, they reach the they form the phagocytic vacuole. So the ingested extracellular particle are known as the phagocytic vacuole. They fuse with the lysosome and form the phagolysosome, or otherwise known as the secondary lysosome, and which are being eaten up by the lysosomal enzymes and form the residual pori, and are released outside by process known as exocytosis, or exocytosis, that is expelling out the cellular contents. This is the difference between the autophagy as well as heterophagy. So autophagy is a process which is completely different from the necrosis and apoptosis. So as we have discussed, autophagy, it is a process where it is a kind of survival mechanism, whereas necrosis and apoptosis are a cell death mechanisms. So nevertheless, autophagy, it has invoked a mechanism of cell loss in various diseases. But it means that autophagy not only helps in cell survival, but it also helps in cell loss. Example we can see in degenerative disease or the nervous system. Degenerative disease in nervous system of the as well as in muscles, where the unwanted cells or already degenerated nerve cells or muscle cells are being removed by process of autophagy. So autophagy has functions in cell survival as well as in cell loss. So in disorders, usually in any disorders, these damaged cells, they contain the autophagic vacuoles, which contain of digestive cell organelles within them. So in any degenerating disorders, usually in disorders which are being neurodegenerative disorders or muscle degenerative disorders, we find presence of autophagic vacuoles in molecular level. This completes the process of autophagy. Thank you.